Boa tarde, é com muito prazer que eu venho abrir essa mesa agora, que é a nova diretriz
It's a pleasure
diagnóstica e
to
terapêutica do
open this
câncer de
panel now,
mama
the
no
now
Brasil.
guidelines
E
for
aí eu
diagnosis and
vou
therapy of
apresentar
breast
os
cancer in
nossos
Brazil. I will
palestrantes.
introduce
O
our
primeiro
three
deles,
speakers.
falando
The
sobre
first of
cirurgia
them
mamária,
talking
será
about
o Dr.
breast
Henrique Lima
surgery.
Couto, que é
Dr. Henrique
coordenador do
Lima Couto,
Departamento de
who
Imagens da
coordinates the
Mama da
Department of
Sociedade
Image
Brasileira de
at the Residency
Mastologia,
Site of
membro da
Mastology,
Comissão Nacional de
member of the National
Oncologia,
Committee of Mastology,
diretor-presidente da Clínica
present
Rede
director
Mama,
of
Rede
the
Mama
Henrique Mama
Salvador de
Clinic
Vidas.
in
A
Belo
seguir,
Horizonte.
a doutora
Then
Angelica
Dr.
Nogueira
Angelica
Rodrigues,
Nogueira
que tem
Rodrigues,
pós-doc em
who had
oncologia
a
por
postdoc
Harvard,
in
é professora e
oncology at Harvard,
pesquisadora
a
da
professor and researcher at the
UFMG e
UFMG,
realizadora do Grupo
and
Brasileiro
she
de
organized
Tumores
the Brazilian group
Ginecológicos
of
ZEBRA,
gynecological
chair de ginecologia
tumors,
oncológica da
heads
ACOG
the
e oncologista
oncology
adjunta
unit
em
of
Clínicas
ACOG
para falar sobre
to
oncologia.
speak
E
about
a nossa
oncology.
terceira
And the
apresentação
third
sobre
speaker
radioterapia será
on
feita pela
radiotherapy
doutora
was done by
Nilciana
Dr.
Maia
Nilciana
Aires
Maia
Freitas, que é
Freitas,
radio-oncologista
who
do
is a
Hospital Câncer
radio-oncologist of the
Araújo
Cancer
Jorge e
Hospital
Hemo em
Araújo
Sebron,
Jones,
em
and
Oncoclínicas em
Sebron,
Goiânia, tem
Oncoclínicas in
doutorado
Goiânia
e mestrado pela Universidade Federal de Goiás e é membro atual da diretoria da Sociedade Brasileira de
of the
Radioterapia.
Brazilian Society of Radiotherapy.
Olá, como vão? Esse é um debate muito importante, que é sobre a Diretriz Diagnóstica Terapêutica de Câncer de Mama, é um documento do SUS, que foi aprovado no
That was
Conitec em
approved
2022, em
in
novembro,
Conitext in
que
2022 in
a gente
November,
aguarda, porque vai trazer
and
muitos
we are
avanços.
waiting because this will bring a lot
DDT
of
são diretrizes
move forward.
diagnósticas e
The
terapêuticas. São
therapeutic and diagnostic guidelines, these official governments that established the guidelines for diagnosis and therapy. It talks about efficacy, cost effectiveness. In oncology, it aims to guide the best approaches in oncology. The most recent publication was 2019. And it's important to understand the difference between clinical protocols and therapeutic guidelines, the BCDTs. These are official documents that are established for diagnosing the disease or worsening health, treatment, the medication, and other appropriate products when available. The dosage, the clinical control, and monitoring verification of results to be followed by the managers of the unified healthcare system. They're based on scientific evidence and consider efficacy, safety, effectiveness, cost effectiveness of these technologies. The PCDTs are effectively what a manager needs to follow. So we're waiting now for the recommendations of the DDT of Connectech in breast cancer. Well, what has changed from 2019 to 2022? In 2022, recognized the importance of diagnosing and testing genetic syndromes with the possibility of personal tracking and risk-reducing surgery that recognizes, in terms of the diagnosis, a procedure, a minimally invasive procedure with histology and immunohistochemistry is the gold standard, and diagnostic surgery should be avoided to reduce the complication rates. And 2019 used to use prognostic clinical TNM staging. Now we use pathological TNM, including the expression of receptors, so that we have an idea of the risk of this disease. So about the diagnosis, it's clearly different, identifying high-risk families, whether by the family history or genetic testing, which allows us to establish specific prevention measures that includes monitoring by mammography and MRI up to mastectomy or oophorectomy to reduce the risk. So recognize that oophorectomy and mastectomy, which did not exist before, but in diagnosis, there's this phrase that has a lot of impact. The initial goal of biopsy is to obtain enough material for diagnosis, always using the least invasive conduct for histopathology to avoid unnecessary excision of benign lesions. The report should include an immunohistochemical characterization, epinephrine receptors, and Ki-67. In staging, we have a change that we use in the practice, which is staging the patient to decide therapy according to pathological and prognostic factors as well as anatomic factors. So we start to use the staging of JTC, which is the most complete of them all. Now, what about surgery? What are the changes that we have seen? In 2019, the main treatment, and it's still recognized as surgery, neoadjuvants in 2019 was recommended only for advanced stages. Now it changes a little. There is an increase in the indication for stage 1 and 2. It's not restricted to 3, depending on the integration of prognostic variables. It recognizes as a gold standard the conversion of accelerated dissection to sentinel node biopsy. It was only to convert a radical to conservative surgery. And now this also to change a dissection to sentinel biopsy, recognized as a pattern in the new DDT as a gold standard, to mark or clip the tumor bed before neoadjuvant therapy to avoid losing this afterwards. Also, as an innovation in lymph node biopsy or sentinel biopsy, it recognized the possibility of omitting the biopsy for patients with luminal tumors A and over 70 years of age with a negative axilla. Well, what changed in these guidelines, the DDT? Neoadjuvant surgery, there's integration of surgery to the modern practices of neoadjuvant therapy. One will be inflammatory carcinoma, irresectable disease, or locally advanced disease, to HER2 or triple negative high-risk cancers, which are indications of neoadjuvant therapy, reduce the extension of surgery in the breast and the axilla. In other words, surgical downstage, or in patients in which the surgical decision should be supported by genetic testing, or that might take time. If the genetic test, you should maybe do neoadjuvant therapy while you wait for the genetic testing. And it also considers the clipping. Here you see this case of a strongly positive axilla in the breast and the axilla with full pathological response. Absence of lesions and the absence of the clip would really make it difficult to assess this patient. About surgery, surgery is the mainstay of therapy in breast cancer initially, and includes intervention on the breast and the axilla. Conservative breast surgery currently defended, and the total of surgery is indicated when the size of the tumor is large, vis-a-vis the size of the breast, or when it's not possible to attain surgical margin, negative surgical margins after multiple resections. Breast reconstruction is usually indicated in patients undergoing mastectomy. It can be immediately, which has relate to better patient satisfaction, or can be late. The breast surgery may be done on the contralateral breast. The biopsy may be omitted in patients with luminal T1N0 tumors in more than 70 years of age. It's important to use ultrasound to make sure that the axilla is really negative. After neoadjuvant, there is a possibility of the conversion of the axilla to 0 and doing sentinel biopsy. If in 2019 there's only down staging for the breast, in 2022 it recognizes that neoadjuvant chemotherapy can help to downstage the axilla. Hormone positive cancers, luminal A and B, and operable tumors, surgery may be conservative with a negative axilla. You should start the treatment with partial surgery. Decision should be guided by pathology and histochemistry. With a negative axilla in these tumors, it will be negative, or rather, it will be conservative surgery. When you do neoadjuvants for these hormone positive tumors, when the tumors are inoperable, or in tumors that require more surgery. You may use it hormone therapy as well. You may use hormone therapy, and it should be considered to convert patients from inoperable to operable in conservative mastectomy and in lymphodectomy. And the lymph nodes, sentinel lymph node biopsy. This is particularly important in luminal B tumors. You can see this in the case of A, neoadjuvant is better, but luminal B, it works better in chemotherapy. Now, adjuvant therapy of HER2 positive patients with localized HER2 positive tumors less than 2 centimeters and negative axilla, they should undergo conservative surgery and adjuvant. The neoadjuvant treatment of HER2 positive tumors, patients with tumors larger than 2 centimeters and positive axilla. It was just staging. Now you have to individualize. In this case, neoadjuvants with chemotherapy and trastuzumab are recommended. For these patients, also need to be included in the public healthcare system, which is not yet recognized as such. HER2 patients with no complete response now recognize that adjuvant therapy needs to be done with T-DM1. And triple negative, patients with triple negative and tumors larger than 0.5 centimeter or 5 millimeters with a positive axilla should undergo neoadjuvant therapy, followed by surgery. And if there's no full pathological response, then cavasitabine. This new guideline reduces significantly this interval between, or this gap that we had in these cases, although the gap still is there. The new guidelines do not bring the possibility of immunotherapy for these patients. Well, we're waiting then for these new guidelines to be promulgated. It reduces a lot the gap, although there is still a gap, but it reduces it quite significantly of what were old practices of surgery for just about everyone to a more personalized approach. But it needs to be promulgated so that it can actually work. So that's it. We're waiting for it. Sleepless nights because a lot of women are suffering because these guidelines are not, although it's approved by the committee, it has not been promulgated. Well, thank you very much. Good. I'd like to thank the organizers of Breastmit and to welcoming everyone and to thank you for this invitation to speak about the therapeutic and diagnostic guidelines which is called DDT for breast cancer. Let's comment on the main changes that we've seen, which CONITEC has implemented. For this presentation, these are my disclaimers. So this is the recommendation catalog of the guidelines for diagnosis and therapy for breast therapy in the universal healthcare system, public government system. This was written in August 2022. And in this context, in April 2011, a law was published saying that the support and incorporation of technologies for the SOS, the public healthcare system, would be defined jointly by the Health Ministry and the National Committee for Incorporating Technologies into the System, called CONITEC. So to bring in new therapies, new procedures, and things like that, and radiotherapy, and what needs to be brought in. This document, it changes a prior document. These are the clinical processes. This now becomes DDT instead of PCDT. This is what we will discuss right now. It's called the diagnostic and therapeutic changes. This is a demand, a request really for guidelines on the responsibility of the Ministry of Health to update these protocols for treating these patients. The method that was used to develop the guidelines was a grading of recommendations of assessment and evaluation according to the Jean McMaster Guideline Development Checklist, a method that uses a grading system according to level of evidence to incorporate new technology, starting with the screening in this document, 2022. Unfortunately, nothing was changed in the previous recommendations. So in 2015, the National Cancer Institute, the INCA, published a guideline for early detection for screening of breast cancer in Brazil, defending screening in the populations of women between 50 and 69 years of age, doing mammography every 2 years. So although there are disagreements since 2013, the Brazilian Society of Mastology have a position for annual mammograms starting at 40 years. And this is the recommendations of the Brazilian College of Radiology, and the government now also has this opinion. It was kept in this new guidelines, unfortunately without changes. Also, the clinical examination of the breast is not recommended, and in the same age group. Now, an important matter that has generated a lot of debate with recent discussions on the Ministry of Health in 2023, now in October, is on balancing the risk benefits. The ministry understands that it's favorable in this age group, but mammography increases the risk of overdiagnosis of false positives, resulting in unnecessary biopsies, besides increasing the radiological risk. And therefore, which was again a position of the medical associations, and the Brazilian Society of Clinical Oncology was also agreed with this. With all this, that may reduce
para rastreamento com as posições contrárias aí que a gente já colocou. Bom, isso foi para rastreamento de câncer de mama. Em relação a tratamento da doença, agora a gente vai abordar pacientes com diagnóstico, os critérios de
the inclusion criteria within DDT are women with diagnosis of invasive breast cancer stages 1 through 4 of the ductal infiltrating subtype as well as lobular infiltrating subtype. This is the scope for this. Now, talking about surgery, a positive aspect that is considered in this norm that gives us some argumentation to fight for our patients to have proper access is breast reconstruction. So it says that breast reconstruction can be immediate, and this brings more satisfaction to the patients. And it may also be at a second time in contralateral breast surgery may be necessary to make the breast more symmetrical, always considering a given reconstruction technique and the need for neoadjuvant therapy to indicate, to decide on the time of indication. But breast reconstruction is established not only of the affected breast, but also to make them symmetrical, to make them more equal. And this is the argument we have to use to establish the access to breast reconstruction in the Brazilian public healthcare network. As far as treatment is concerned, talking about surgical treatment, still the approach of brain metastasis was also considered within this topic of surgery. And here they also considered treatment modes of local control surgery, and also they mentioned radiation therapy. And we have to say something here, a caveat. Much progress has happened in the treatment with medication of central nervous system metastasis, especially with HER2 positive cancers. Data about drugs, anti-HER2, trastuzumab deruxtecan, with excellent efficacy in the central nervous system, especially in patients that were not submitted to previous local control. It is very important to consider this type of medication for these patients. So this is a discussion about the surgical approach or radiation therapy for brain metastasis. As far as radiation therapy is concerned, they considered treatment evolution, especially on devices. This is not within the document. This is very much welcome. Brazil has great difficulty of access to radiation therapy. The mean distance, patients go over 70 kilometers for treatment in average. So consider that most patients live in large urban centers. This number is very exaggerated for women who live distant from the urban centers. Now, from the viewpoint of the treatment modes, they considered conventional treatment, hypofractionated treatment, and the ultra hypofractionated treatment mentioned as treatment modalities possible and welcome for the treatment of patients depending on the risk criteria. Now, moving on to systemic treatment, where there's a large number of ideas that we still need to discuss. There has been gain from this norm, but still there's a lot to be discussed and added to, considering the revolution in the systemic treatment of breast cancer in recent years. So for the systemic treatment, a first important point is that we need to consider the lack of considering genomic tests for decision-making in patients with luminal disease. This is a passage of the document bringing it to different situations. We have to use clinical and pathological prognostic variables and also risk calculators. And we understand that these risk calculators are fragile when compared to genomic tests that are more precise. Considering the definition of these patients that may require adjuvant treatment of chemotherapy, and we need to bring this to discussion so that at some point these patients may have access to these tests escaping toxical treatment. A positive point of this new norm and the luminal disease was considered the hormone adjuvant, extended adjuvant hormone therapy. Minimal duration is not restricted to 5 years any longer. It can be considered, we can consider the use of tamoxifen up to 10 years in premenopausal women, or the use in premenopausal women as long as there's a block with proper variation to do the switch to 2 or 3 years of aromatase inhibitors. And for patients using aromatase inhibitors and the adjuvant since the very beginning, but that have a higher risk criteria, must also consider the possibility of extended adjuvant coming up to 7 or 8 years. So consider extended adjuvants is a very positive point. And still missing here in the adjuvants of luminal disease is the lack of the use of cyclin inhibitors for higher risk patients. So right now in 2023, we know that the use of 2 cyclin inhibitors, abemaciclib and ribociclib, used in adjuvants in patients who fulfill the criteria according to data from Monarchy and Natalie studies, they have reduction in the risk of invasive disease, relapse of invasive disease. And this is something that has to be slowly discussed and added to these protocols. Another positive point is the use of adding zoledronic acid for those patients with luminal breast cancer, and it was considered in patients using aromatase inhibitor and adjuvants, and the possibility of using zoledronic acid every 6 months for 3 years. This is also a gain, not only for the bone health of these patients vis-a-vis reduction in risk of fracture, but also reducing the risk of cancer, since the use of zoledronic acid in neoadjuvants can be a protective agent in that aspect. In HER2 positive disease neoadjuvants, we follow without the support to use double block, knowing that this increases complete pathological response, reduces the likelihood of disease relapse. So we still have this problem. And that's a flow chart here for triple negative breast cancer. It is inverted. We have to be careful here. So in patients with disease larger than 0.5 centimeter or positive axilla that are not going to surgery, these patients with more than 5 centimeters and positive axilla If they fulfill these criteria here, there should be a yes here. They go to neoadjuvant chemotherapy. Controversial is 0.5. Traditional risk criteria, 2 centimeters or positive axilla. The patient starts with a neoadjuvant chemo and then surgery. And in this context of triple negative disease, the use of immune therapy, regardless of TBL1, has a significant impact on the rate of complete pathological response, consequently reduction in the risk of disease relapse in this context of neoadjuvants that was not considered in this new guideline. Now, as within the HER2 positive and triple negative contexts, in HER2 positive patients of higher risk, we feel the need for a double block with pertuzumab, which is not considered in the context of initial disease, only in the context of advanced disease, and immune therapy in this context of triple negative initial disease is not considered. A positive novelty is adding TDM1 for patients who will not go to complete response within the context of HER2 disease, having then residual disease, they may receive TDM1. It is important, although despite this approval, it is not available in the public healthcare system. This is another recent problem. Despite approval from CONITEC, the delay in providing payment for this. I will conclude here with important addings and important things missing in this new norm. Important things considering breast reconstruction as a right for the patient's TDM1, adjuvant TDM1, extended monotherapy for patients who use tamoxifen, as well as for patients who used aromatase inhibitors, being considered 10 years of tamoxifen or 7 to 8 years doing a tamoxifen switch to aromatase inhibitors, and also in patients with aromatase inhibitors considered extended adjuvants coming to 7-8 years if the patient is a high-risk patient. Also considered the use of adjuvant zoledronic acid is important for the bone health of patients, reducing metastasis, and the positive use of cyclin inhibitors in advanced disease, also considered as positive and added by CONITEC. However, still right now, and we're talking now about the end of October 2023, still not paid for and still not available in the standards of treatment. Benacyclib and ribociclib has been approved as class, but we are waiting for the effectiveness of supplying this to the patients. And I'll talk about what is still missing, what we want, where we want to get that's still not in the document. Genetic tests looking for pathogenic variants. This has an impact in the treatment of patients, especially a BRCA mutation, and also to prevent disease in the patient, second primaries and family members. The lack of genomic tests for risk definition, being able to spare patients from chemotherapy, vis-a-vis their risk, adjuvant cyclin inhibitors. There's a growing body of data on this class of medications. According to Monarchy and Natalie studies, double HER2 block in neoadjuvants. There's enough data for the large benefit of the use of trastuzumab together with pertuzumab in this clinical context, and it is not included here. Immune therapy in the initial disease and also in the advanced disease, the use of IPARP inhibitors in the initial disease. There's a gain in global overall survival in high-risk patients. Consider the use of olaparib and adjuvants. And an important problem because of the high cost of these medications, but highly efficient, is ADCs, especially trastuzumab deruxtecan. In the context of advanced disease after exposure to trastuzumab, hypertuzumab in the first line today is the drug of choice for these patients. At some point, we'll have to sit down and discuss this cost and how to make it feasible, adding such an important drug so that the Brazilian population, the public healthcare system, should also receive this benefit. Well, I would like to thank you very much for your attention, and I will be available for questions later on. Thank you very much. Hello, I'm Nilciana Maiares Freitas. I'm radio oncologist here in Goiânia in the Cancer Hospital, Araújo Jorge Cancer Hospital, in the Oncoclinics group in Goiânia, Goiás. I'm here to talk about the differences in the new diagnostic and therapeutic guideline in breast cancer, comparing with the older one and this radiotherapy modality. Now, to start, the previous modality was published in 2019. And this new recommendation now from August 2022, as a matter of fact, was a meeting we had still in the year of 2019. So 3 years ago. This is very important so that we may establish the differences. The older guideline from 2019 indicated radiotherapy, postoperative radiotherapy in at least one of these conditions. 4 or more positive nodes, conservative surgery, positive margin, as long as it was not possible to have a new surgery, tumors larger or equal to 5 centimeters in case of mastectomy, or in the presence of 1 to 3 involved lymph nodes. They should analyze case by case and discuss the risk-benefit of therapy, of treatment. This is what they said in the previous standard. And it recommended the conventional fractioning, which is what we do for 50 gray and 25 fractions for 5 weeks. And for those patients that would still require an additional dose reinforcement, boost was sequential for 2 or more or 1 week later, a total of 6 to 7 weeks in the treatment of breast cancer. However, it started to suggest the hypofractioning techniques, which would be to increase the dose per day and reduce the total number of fractions to 13 or 16 fractions. And the rationale behind this is because moderate hypofractioning had the same likelihood of control, local regional control, than the conventional fractioning system without increasing side effects or even without cosmetic loss. Contraindication now for this of 2019 is that one should not do hypofractioning in patients submitted to chemotherapy, in patients submitted to mastectomy, and also having the need for lymphatic irradiation. So bear in mind, these were the norms, the previous norms of the DDT. And in addition, it also restricted the indication of hypofractioning only for women older than 50 years, initial tumors, PTU, T1 or T2, PT1 or PT2, necessarily negative axillas and positive hormonal receptor. For those patients that had a high histological grade or having vascular embolism peritumoral could not receive hypofractioning as well. And only those patients with negative margins after tumor resection were candidates to hypofractioning according to the older legislation. It already talked about, in the older proposal, about partial breast radiation therapy, saying it was possible to have many techniques involved as long as it was only done in centers with controlled studies. Look at what they said here. You could not do any radiation therapy, partial radiation therapy technique if not within a clinical trial. Indications: patients with a breast of low risk local relapse, initial stages without axillary lymph node involvement. And it advocated this technique of intraoperative radiotherapy within the surgical center. It was not recommended to move patients from the surgical center all the way to the radiation therapy room. This would be a regulation, a control done by the manager, and it should be done in intravenous equipment with a photon energy or the Elliott equipment that is considered linear with the energy from electrons. This was the older recommendation. Also, it was recommended to associate palliative radiation therapy in case of brain metastasis, bone metastasis, and neoplastic medullary compression. And for those patients that didn't have response to chemotherapy or even to previous hormone therapy in locally advanced tumors, they could also use preoperative radiation therapy. The new norm was we had a meeting in Brasilia in May 2019. So I remember, once again, 4 years that we had this recommendation 4 years ago. And based on radiation therapy, we had myself and Martha Nassif, who is from Porto Alegre. And what was recommended for adjuvant radiation therapy, it follows exactly the same indications. We had no changes here whatsoever. Now, as far as hypofractioning is concerned, this was the biggest change. Here, we already recommend not the conventional fractioning, but hypofractioning. And it could be done after conservative surgery as well as mastectomy, differently from what was advocated back then in the older norm. The recommendations for moderate hypofractioning in 15 or 16 fractions for 3 weeks, and the novelty here would be to use the ultra hypofractioning technique of 26 grays in 5 fractions in 1 single week, or even doing 5 fractions in 5 weeks. And in 2019, fortunately, we had data published with ultra hypofractioning, what helped us have this and the norm of our patients here for Brazil. Now, the indication, this was very much discussed during the meeting, is that we established that if the patient were to use hypofractioning techniques, one should use CT scan to plan the radiation therapy as recommended by the Brazilian Society of Radiation Therapy. It is interesting to say that this was a topic of much discussion because the managers from Conitec discussed what would be the cost increase if all the patients with breast cancer that required radiation therapy would require a CT scan, having seen that most of the radiotherapy services in Brazil do radiation therapy without CT scan in the 2D era. And we said that if you were to do hypofractioning, it would not be safe to use a reduction in the number of sessions without proper CT scan, running the risk of increasing side effects. And with this, you can see that there was a broadening in the scope of indication for hypofractionated radiation therapy. And in the same year, before our meeting, we had a consensus meeting in the Brazilian Society of Radiation Therapy. This meeting happened in March of 2018, and we had a publication of the data making sure that it would, yes, be possible to do a moderate hypofractioning for patients with breast cancer in a way that would be very similar to what was published by the consensus of the hypofractioning from Astro. Interesting is that the change in the guideline from 2011 to 2018 really matches what we also recommended. Hypofractioning would have no restriction as far as age is concerned, without restriction as to clinical staging of these patients. Even if the patient undergoes chemotherapy as well, it is recommended as long as we would have a dose homogeneity in the entire tissue to guarantee a reduction in side effects for these patients. And fortunately, I bring here data, more recent data, in which we did an update of the data from the Brazilian Consensus of Radiation Therapy, Hypofraction Radiation Therapy of the Breast, May 2023, during the Brazilian Breast Cancer Symposium. So this happened after having the DDT meeting from 2019. But we bring here this novelty that a lot of things changed from 2019 to now. So it is time to review the data from this norm so that we can add it safely, add the techniques of hypofractioning. This is all based on the publications from the FAST trials. These are studies from the United Kingdom and the Fast Forward trial that came to make sure that we can do 5 sessions in 5 weeks or 5 sessions in 1 single week, making it easier the lives of these women, reducing treatment time, and making possible for these women to go back home to their homes as well as to their families. This was the goal, having so many difficulties that we have in Brazil and also in the world. This is safe because 5-fraction radiation therapy managed to reduce the risk of side effects for the breasts of these patients as radiodermitis. And this is very important. having this report that we had according to the Brazilian Society of Radiation Therapy, RT 2030, in which they established that 75% of the health regions of our country do not have any radiation therapy equipment. It's a huge scarcity having such a huge country, the lack of equipment in Brazil. What results in longer travels by these patients all the way to the large centers that have radiation therapy regions, for instance, as Amapá. The patients have to travel more than 1,400 kilometers looking for treatment. And the average of the patients, the general average, they have to travel about 72 kilometers in average. So we have to make it easier for these women to have access to the public healthcare system. Hypofractioning is the big solution so that we would no longer have death caused by cancer because of the lack of radiation therapy devices in our service, as we have data published also by the Brazilian Society of Radiation Therapy. And the new guideline for breast cancer diagnosis, partial radiation therapy is also stimulated, but the main issue here is that we don't have to have centers with controlled studies. And we have a number of techniques such as external radiation therapy to do partial breast radiation therapy, brachytherapy, and the intraoperative radiation therapy. And the indications remain the same. Patients of very low risk with a low risk of relapse, initial staging, and patients who do not have the possibility of axillary lymph node involvement in a clinical way. As to palliative radiation therapy for breast cancer, indication of pre-op radiation therapy remains the same as to the one indicated before. And the difference here in the new recommendation of the guidelines is the possibility of a new technique that we also say is the ablative radiation therapy, radiosurgery, or fraction stereotactic radiation therapy. Patients who will benefit are those patients with oligometastasis that have a very low number of metastases, where we can provide high doses of radiation and a treatment that is very much focused on the tumor with very low morbidity and an excellent tumor control in the long run. So these are the recommendations, and the main difference we have with the guideline of 2019 is, and I invite you all to join us in our Brazilian Breast Cancer Symposium in 2023 from 16 and 18 of May, 2024, as a matter of fact, next year. And I hope to see you all there again in our city, our dear city of Pirenópolis here in Goiás. Thank you. Congratulations, Dr. Henrique, Angelica, and Luciene, for all these great presentations, very clear. And now we'll move on with our panel. I'd like to introduce you our moderators. I introduce Dr. Soraya Paula Paim, who's a mastologist, a physician, at the Municipal Secretary of Health of the City of Belo Horizonte, the coordinator of the Municipal Committee of Oncology until October this year, and a mastologist at Luxembourg Hospital. And also I introduced Dr. Leandro Gomes Ramos, who is a clinical oncologist of the OncoMed group. He is the coordinator of the oncology service of Ipsengi, clinical director of the OncoMed group. And our third debater is Dr. Leonardo Shamon, who has a medical residency in radio-oncology by the National Institute of Cancer, INCA, radio-oncologist of Radio Care of Felício Roxo Hospital, and radio-oncology of the San Francisco Institute of Radiation Therapy. Good afternoon, everyone. I would like to yield the floor first to Dr. Soraya for her remarks to start with. Her mic is mute. Her mic is off. O microfone dela está desligado.
Soraya, tá no mudo. Habilito.
Aí, obrigada, Henrique.
Thank you,
Então, assim,
Enrique. So I would like to thank you for the invitation. I'm a member of the oncology committee. I have been for 20 years. Now moving on to the early diagnosis program and control of the breast cancer for the state of Minas Gerais, and Belo Horizonte will be part of this program. There is a financial support for this program for patients to manage to have faster visits to the physicians and faster tests, mammography, mammogram, ultrasound, biopsy. And I hope that this can help in early diagnosis and early onset of treatment, because it is meaningless if you diagnose it but don't start treatment quickly. This is a huge progress, this new standard, this new norm. It's too bad it took so long to be published. It hasn't been yet, and I have known that it will transform it into a protocol soon. So this is a stronger document, and this transformation will be based on the DDT, on the norm, with the participation of CONITEC and other members. So it will really encompass, but it will become, as of a rule, even more than a northern of authorization. It is a rule of authorization for managers. I consider one of the major progresses of this PCDT, this norm, would be neoadjuvant treatment, because in addition to being able to promote neoadjuvants for smaller, for lower stages of a not very aggressive disease, it will also enable us to have status closer to the reality, because what happened before is that they staged everyone as a 3 in the PAC, which is the funding document. So I change it 2 to 3. If it passes by the regulator, it is authorized as a 3. So Brazil had a large number of over staging. So patients are stage 3 here. There are a lot of them, because my patient, if I cannot do neoadjuvant 2, my patient stage 3. So we had a lot of 5.1 tumors in here at one point. This to benefit the patient. Of course, another important progress is to be able to do adjuvants after having a previous. This is a fundamental pre-requirement.
It's a premise to have new adjuvants, then you don't do adjuvants, and this is about to change. I think, therefore, more than anything else, it is a move forward, because, for instance, radiotherapy, after changing the radio procedures, the authorizer didn't have this problem anymore. If you did it in a week, in 2 weeks, 3 weeks, the payment is the same. So a radiotherapist had more autonomy. I missed a few things in these new guidelines, and maybe might come on, which is the colony stimulating factor. There's no perspective this for the breast. If they want to use it, we'll use it, and will be paid within the procedure of chemotherapy only. And we know there are many schemes that would really require using colony stimulating factor. And the other thing that I think that I miss is patients that have a recurrence of conservative therapy. You have to throw it into chemotherapy in palliative therapy. And this patient is very different from metastatic disease, particularly conservative therapy. Patients treated conservatively have an expected rate of recurrence, not necessarily metastatic disease. Is trastuzumab only for visceral disease. And if there is other types of metastasis, it will not be used. It's not authorized yet, even with this new DDT. And about the state of Minas Gerais, we have a law, state law, October 2009, from them that assures genetic testing and prophylactic therapy. It doesn't yet work yet. At the end of 2023, nothing has happened. Positive points, we have a federal law now stimulating breast reconstruction of patients undergoing mastectomy, including making those sides symmetrical. I think this is a move forward. So let's wait and see what happens, with what already has of gains at this point, this previous document, and maybe with some further gains. Thank you.
Muito bem, Soraya. Agora eu
Very
queria
good,
convidar
Sarah.
o
Now I'd
Leandro
like to
para fazer
invite
suas
Dr. Leandro
considerações.
for his comments.
Ok, pessoal, então
Well,
muito obrigado pelo
so thank
convite,
you very much
Henrique,
for the invitation.
parabenizá-lo também, Henrique, pela
Congratulating
palestra,
Henrique
Angelica
for
e
your
Luciana,
talks, and Angelica, Luciana, and everyone else,
situarem
and
aí
who has
direitinho do ponto de vista do que
contextualized us very well
mudou
in terms of what has
nessa
changed
última DDT.
in this
Antes de
latest set
começar,
of guidelines.
Henrique, eu
Before
acho que,
starting,
né, a gente precisa ter
we
em
need
mente,
to bear in mind
Luciana colocou de forma muito
what Luciana
clara
said,
que
and she
o
did it very
Brasil é um
clearly.
país continental,
Brazil
as
is a huge
dificuldades que a
country.
gente tem
There's a difficulty that we have
país muito
in a number
heterogêneo
of things
de
because of the
Estado
fact that
e
the
de
country is very
recursos, né?
heterogeneous,
A gente tem
different states, different level of
vários
resources.
dificuldades que
There
os
are places
pacientes
where patients find it difficult
não
even
têm
to
acesso a um equipamento de
having
radioterapia.
access to radiotherapy equipment.
E, em
So,
contrapartida, a gente está
on the other hand,
conversando aqui sobre
we're talking here
remédios, sobre
about
drogas que
drugs
trouxeram
that
benefícios de
have
forma
brought
muito
benefits,
significativa. A Angelica
very
colocou de
significant
forma muito
ones,
clara
as Angelica showed us so
drogas
clearly,
importantes no nosso
important drugs for
arsenal,
for us to use medically,
por exemplo, o trastuzumab
and
deruxtecan, que é o
all the
pembrolizumab,
various pembrolizumab
ganhos
importantes,
mas
and
com
other
um
things
custo
that have
muito
brought
grande,
important gains,
e que a
but
gente
that
tem
are
que saber
costly, and we have
trabalhá-los
to be
dentro
able to use
desse
them
contexto
correctly
de país
in this
continental que a gente
context
tem.
of a
Então, é
huge
trabalho
country in which we
hercúleo
live. So this is
nisso
really,
de
it requires a
tentar
great effort to try to
recursos
reallocate these
para que
resources
todo mundo seja
so
beneficiado.
that everyone is benefited.
Dito isso, essa nova DDT, ela
These new
trouxe
guidelines, therefore,
ganhos, né, sem
brought
dúvida nenhuma,
gains, certainly,
o Henrique comentou, a
like
Soraya
Henrique
reforçou e
commented,
a
and
Angelica
Soraya and Angelica have reinforced in their comments, which is in neoadjuvant therapy, possibility of us treating the disease like we treat with in supplementary health, stage 2 patients with more than 2 centimeters of a breast node or a breast tumor. This is a huge gain for us to being able to bring real data to the play and doing this effectively rather than inundating our public healthcare system with stage 3. So in the analysis, or in our statistical analysis, that doesn't work very well. So this was an important gain. Now, also an important gain, like Angelica commented, it's a pity that this is not yet promulgated of us using in adjuvant another ADC, which is a particularly if we have no biological response, and certainly this should be promulgated soon, surely. Extended adjuvants. That's a very good point to be able to have this right now. And CDK4, which we'll have to wait a little for that. But I think I was impressed also, and we always comment on this, on the importance of an early diagnosis. And still, we can't do this. We can't do mammograms at age 40 to this day. So mammograms are recommended from 50 years of age outwards. And we know, I mean, this could be solved simply, and we know that it has a huge impact on the lives of these patients when we are able to make a diagnosis earlier on of this disease. Genetic testing, like Angelica commented, fortunately, some even in health insurance medicine, these are not necessarily easy to attain. Often the patients need to pay themselves for these tests, and it's important that the provider understands that genetic testing may seem expensive, but it allows us to do certain forms of therapy that would have a lot of consequences for the patient. So in this context of a huge country, a well-indicated genetic testing in these patients would be interesting, and it would be a gain for the system as a whole. Other than that, congratulating the speakers they were able to briefly summarize the new guidelines in public health care in Brazil and with the needs that we have for the future. The impression is that we have taken an important step forward to improve the care of these patients with breast cancer. Thank you.
Bom, Leandro.
Very good,
Eu
Leandro.
queria
And now,
chamar a Luciana para ver se ela tem alguma
Luciana,
outra
do you have any
consideração,
other
além das que ela
comments
já fez durante sua
besides the one that you
apresentação
did in
sobre a
your presentation
radioterapia?
about radiotherapy?
Olá, gente, boa tarde. É um
Well,
prazer
good
e uma honra
afternoon.
estar
It's a
aqui com
pleasure and honor
vocês.
to be here with you.
Sobre os dados
Uh,
da radioterapia, eu
about
mencionei
radiotherapy, I think
o ganho
that
principal
the
é a
main gain
incorporação do
is to
ultra-hipofracionamento, porque
incorporate
a possibilidade de fazer
ultra-hyperfractioning,
radioterapia em
the
5
possibility of
sessões, a
doing
gente consegue encurtar
radiotherapy in
mais
5
ainda as
sessions. With that, we
distâncias e
can
facilitar o
shorten the
acesso da mulher
distances and to
a
make
fazer o tratamento
it
de
easier
câncer de
for
mama.
women to
E
access
além
treatment
disso,
for breast
na
cancer
DDT
therapy.
anterior,
And in the
não se
previous
falava
guidelines,
sequer
we
em
didn't speak even
radiocirurgia,
about
que a
radiosurgery,
radioterapia para
radiosurgery
tumores metastáticos
for
secundários ao
metastatic
câncer de
tumors in
mama
the
é uma
brain in
modalidade que já
breast
é muito
cancer
antiga
is
e que a gente
quite an old
sabe do grande
modality. We know
benefício
of
dessa
the true benefit
radiocirurgia
of
no
this
controle
radiosurgery
local da
in
metástase cerebral.
controlling locally
E a gente tem a
brain
possibilidade também
metastases, and we
de
have the
radiocirurgia
possibility
com
of doing
técnicas
radiosurgery
debatidas,
and ablative
que é a
surgery,
cirurgia extracraniana,
which is
também chamada
extracranial
de
radiosurgery, which
SBRT,
we call
em
BRT.
algumas pacientes com
So
câncer
for
de
some
mama
patients
metastático,
with
desde que seja
metastatic disease, as
oligometastático,
long as
melhor
it's
ainda. E se é assim,
oligometastatic, they may
ir no
benefit
tratamento
certainly
local
of
com
local
técnicas
therapy
ablativas, mas
with ablative
obviamente
techniques,
vai
but
variar a
obviously
questão de
uh,
tecnologia. Não são
has to do
todos
with
os centros de
technology.
radioterapia que
Not
têm
every
essa
unit
possibilidade,
have the
mas que pode
possibility of having
fazer
this method,
muita
but
diferença na
certainly
vida dessa
it can
mulher.
make a huge difference in the
Basicamente é
lives of
isso.
these women. So basically that's that.
Angélica,
Angelica,
queria te chamar também para dar uma palavra aí
oh,
para a gente.
a final word from you.
Olá, pessoal. Parabéns
Hello,
pelo
folks. Well,
evento,
congratulations.
sempre
This
de
event
grande
always
relevância e
of
gostei
great
muito dessa
relevance, and
mesa
I like
que
this
trata
discussion
dos
very much.
desafios e agora
Talking
novas
about the
soluções para
challenges and
pacientes
new
tratados no
solutions for
sistema
patients that
público.
are
Acho que
treated in the
trouxe nos
public healthcare
slides
system.
finais, né, as
The final
presenças notáveis e
slides,
ausências
there were
notáveis,
important
mas eu acho que a gente
uh,
deve destacar
points,
positivamente,
but
sim,
certainly you
o
have to
sistema
look
público
at
de
this
saúde
positively,
se
the
posicionou
positive.
muito pouco nos últimos 20
Uh,
anos.
in the last 20 years, it had
Muitos
done very
anos,
little
né,
in this
pela
area. I
própria
say 20 years
jornada aí há 20
because
anos, e ter
a
essas
lot of this has not worked.
incorporações
And to have
agora
these
nunca
new
vai ser no
approaches is much
ritmo que a
better.
gente
It will
gostaria, mas
never
isso
be
não
in
tem
the rhythm that
mudado,
we
né,
wanted
Leandro?
it, but
A
even in
gente,
private healthcare,
infelizmente, a gente
uh,
entrou num momento
things
de
still lag
grandes
a little.
incorporações na oncologia que fez
We
o
are
sistema
incorporating
privado
many things
tem
in
tido desafios para essas
oncology,
incorporações
and this is a
acontecerem. Mas a
challenge
gente
for
não
this
pode
to
se
be
eximir
solved.
dessas
But we
discussões, certo?
certainly have to be part
Existe
of
uma
these
revolução
debates.
em andamento e a
There
gente
is an
precisa
ongoing
posicionar.
revolution, and
E
we
se a
have to
gente dá
position
conta, se a
ourselves with
gente
that.
não dá conta,
If you
a
can do
não
this, we
discussão
can't do
é
that.
o pior
Not
caminho. Mas eu
discussing is the
avalio muito
worst
positivo essas
thing. And so I'm
incorporações.
very
Acho que são
optimistic about
ganhos
these
muito
things,
grandes.
important gains
Não
for
estão
us.
concluídas, por exemplo,
They're
os
not
inibidores de
concluded, of
ciclina, que
course,
trazem
such
ganhos
as the
de
cyclin
survival global, a
inhibitors that
forma de financiamento agora, que foi definida de
bring
novo
gains
pelo
in overall
governo Lula,
survival,
mas
new
também
forms of
abre caminhos
financing,
para outras
but this opens the
doenças.
path for
Eu
new
espero que a
disease as
gente,
well. And I
quando
hope that
tiver esse
we,
documento, a
from
gente
this
comece a
document,
ter fóruns de
we
discussões
begin to have
contínuas
forum
e
for
não
ongoing
pontuais,
debates,
porque é isso que a
not
oncologia
simple
exige. Retiradas
debates.
de
We need
tratamentos que não tenham mais sentido, como
removal of
ablações de ouro,
therapies that
posicionamento quando a
are
gente não
no
dá
longer
conta.
applicable,
Isso é
positioning
mais
ourselves. This is
compromisso, é
all we can do
respeito
and what we
institucional com a
cannot do.
sociedade.
This
Assim que eu
is
vejo o
respect
futuro
for our
possível
society.
para a
This is
gente nesse
how I see the
desafio do
possible
destino
future in
mulher
this positive
no
debate,
controle do câncer
which is
gestativo.
controlling cancer. In other words, controlling cancer has
Muito
arrived,
bom,
if you want.
Angélica.
Very good,
Eu
Angelica.
confesso que,
Now
enquanto
I confess
mastologista que
that
trabalha
as
também
an
na rede
hematologist that
pública,
works in the
eu
public health
aguardo ansiosa
care
aí por
system, I'm actually waiting
essas
for
alterações e a gente
these
realmente
changes, and
quer
certainly we
diminuir o
want to
número de
reduce the
axilas que a
number
gente
of
acaba precisando
axillas
para esse
that we end up
terciário
having
da
to
sociedade
dissect in the
adjuvância, né,
absence
no
of
estágio 2.
neoadjuvant therapy in
E
stage 2.
queria convidar o doutor
Well,
Henrique também para
Dr.
trazer essas
Henrique, I think it's
considerações aí
you're the
do
one with the final
debate.
comment on the debate.
Boa noite a todos, né?
Good evening, everyone.
Das considerações, eu queria mais uma vez agradecer
Once
a
again, I want to
participação, a
thank all
generosidade
of you
de
for
todos
participating
e falar que um congresso
and
de
to
maior
say that
escalonamento,
this
no
conference of
Brasil ou no mundo
the
é muito difícil de fazer e a
scalinating
coisa só
is
tem como ser
challenging,
feita em muitas mãos.
and it needs to
Várias
be done with many
decisões
hands
aí,
together,
obrigado a
many
todos que
decisions.
tiveram
Thank
esse
you all for
tempo
this, who took part
para discutir.
and who gave us this time to
Como
debate these things.
o
and how we can lead a movement or take part in a movement to de-escalate therapy. And we need to talk about this in our duties. We're always focusing on increasing the scale. And that's what oncology has done. neoadjuvant therapy, but not taking into account the possibility of descalinating with a prognostic genetic panel, as we or testing, as we heard here. And we fixed on that patient with benefits, and we're forgetting how much we are treating those that are not benefiting from that but having consequences. So the NNT is essential. And then you come to radiotherapy. In radiotherapy, the main line of research is the opposite of that of oncology. It is to descalinate. It is hyperfractionate. Sometimes even further, it's localized radiotherapy. You see, there are two oncological specialties, two types of oncology, but basically research of radiotherapy is the inverse of what is done in the rest. So we see two important movements. While in surgery, we had significant moves forward, and I have to mention this very well, which is the possibility of doing neoadjuvants to descalate axillary approaches and dissection. This is recognized for the breast and now the axilla, and even selective omission of axillary surgery. This is important. So we need to start to use these resources in a more rational manner. So if we want to escalonate with the cost that this involves, we need to descalonate something else, those that don't need, so that you can have redistribute your resources and your costs. So I think this is a balance that we're looking for today. Reduce costs on one side and side effects and costs for those that don't need it, so that we can have the resources for other modes, more modern approaches for those that really require these new approaches. For that, we need to struggle with economic models. I had the opportunity of publishing a study on economic models. I can tell you it's a huge challenge. It's a huge challenge, these studies of economic models. We see very little studies of this in our studies and in our graduate courses. But these are studies that have a huge effect and that can be applied immediately to our social context. They're very important. Maybe we don't have this dimension, this view of these things, of doing these kinds of studies, but economic studies are studies that have a huge social impact.
Muito bom, doutor Henrique.
Thank you, Dr. Henrique.
Alguém quer fazer alguma consideração inicial?
Any other comment?
Ou, desculpa, alguma consideração final?
Or any other final comment?
Eu queria fazer uma colocação para os colegas, queria a opinião deles, porque
I'd like to hear opinion of the colleagues because it wasn't the previous guidelines and it's programmed for this, which is actinic oophorectomy.
Para mim é uma coisa jurássica.
I think this is so Jurassic, but it's there as a possibility.
Sabe assim, eu até arrepio para ela.
I find it so strange to have something like this to take a patient before menopause and do actinic oophorectomy.
Sim, é bom comentário, porque
It's a good comment because technically it's quite complicated to locate this ovary, to do a good location of the ovary, as well as the tomography that we need for planning. We also need to have precise location, even or an MRI as well. So the dose for actinic ablation of the ovaries is a low dose. We can do this in just a few sessions, but planning is not easy. It's not simple at all. I confess to you that when we've done this, in fact, very few come to us, patients for this type of actinic ablation of the ovaries. But when we get them, technically, it's not something easy to do.
Mas quando vocês recebem, vocês contestam.
Do you question this? Because
Eu vi que isso está ficando pouco mais frequente aqui em Belo Horizonte.
I see this is getting a bit more frequent in Belo Horizonte.
Não tinha. Aí de repente,
We didn't have this, and suddenly 1, 2, few, 3, and it starts again.
A consideração era, tinha duas considerações, uma porque
One,
quando eu estava, né,
when I was auditing this, I would question them. So they thought, why is she doing this? No, I'm protecting patients. Was that there was no way of doing surgery because the line was too big for the surgeon. And the patient has no possibility of doing this by surgery, and so then nothing else can be done.
Sim, eu acho que isso cabe muito à discussão
Well,
multidisciplinar, né?
certainly
Então, se
this
a
needs to
gente
be
chega
discussed in a
para fazer uma
multidisciplinary setting.
radiação para
Patients that
ovulação
comes for
ovariana,
radiation to ablate the
certamente a primeira
ovary.
coisa que eu vou
So the
fazer é
first
ligar para
thing
o
I want
colega
to
que
do is
encaminhou
to
para saber do porquê que
phone
aquilo
the
indicou.
college and say, why are you sending for this?
E tudo
Why
bem,
are you
pode ser
referring the patient for
deliberante
this
e
method?
tudo, mas também
The line
para
might be
fazer uma,
good, but
uma
to do
ablação activa
ablation,
ovariana,
ovarian
ela também
actinic
pode
ablation,
esperar, não é caso de
patient,
urgência.
it's not an
Então,
urgency.
aqui
Therefore,
na nossa região de Goiânia, no
in
Pronto
our
Socorro de
region in
Câncer,
Goiânia, in the cancer
onde eu
hospital
trabalho, a gente tem um
where I
volume
work,
muito grande
we
de
had a
pacientes que
huge
são
volume of
atendidos, inclusive
patients who
é
are
o
seen,
único hospital
the only
que faz
hospital
tratamento de
that
radioterapia
treats
pelo
with
SUS em Goiás.
radiotherapy in the state of
Infelizmente, é
Goiás
uma
for
triste
the
realidade que
public
a gente tem.
healthcare system.
Nós
This is
não
a sad
recebemos esse
reality
tipo
we
de
have.
paciente para
We don't get
tratar.
these patients to treat.
Rapidamente, eu só queria
Well,
participar
I'll just
disso como
to
ginecologista.
participate as a gynecologist.
Isso tinha sentido
This
antes
had
da
meaning, had
videolaparoscopia se
sense
espalhar.
before video
E
laparoscopy of
quase que todo o Brasil. Acho que com os
doing
procedimentos
this in all Brazil with the new procedures in laparoscopy. It doesn't make much more sense.
Eu acho que podia estar na DDT, sabe, Henrique? Que põe
It
lá
should
como
be included
opção,
in DT as an option,
sabe? É
the
uma coisa
guidelines.
complicada. E aí
It's a bit
o oncologista
complicated, isn't
também
it?
quer
And
que
the oncologist
a
puts
TAP
that
não
because,
cobre,
of course,
por
well,
exemplo,
you see,
inibidor de aromatase
the
junto com
aromatase
auxílio
inhibitor is not
ovariano em relação a
paid
isso.
with the ovarian
Então,
block,
não pode
so
medir
there is
dessa
cost,
forma,
but
né?
you
Num
can't measure
paciente
it that way
oncologista jovem,
in a young
nós
oncological
estamos
patient.
falando de paciente
We're talking about
pré-menopausial.
patients that before menopause.
Eu queria agradecer a
Well, I'd
participação
like
de
to
todo
thank
mundo
all of
da
you for
mesa
participating on this panel,
e queria
and
passar a palavra
I yield
agora
the
para o
floor
Dr.
now finally
Henrique
to
finalizar
Dr.
a
Henrique
mesa. Acho
so
que
that he
ele
can
vai fazer umas
close.
considerações aí
I think
finais
he
do
makes a
dia. Um
few
abraço a todo
comments
mundo.
for the
Muito
day,
obrigada.
and thank you all very much.
Bom, gente, agradecer
Well, I
primeiro
just want to
ao nosso presidente,
thank
Dr. Tufi,
Dr. Tufi, our president,
que
and
nos conduz, presidente da
uh,
Escola
uh,
Brasileira de Mastologia,
the president of the Brazilian
Guilherme
School,
Novita,
School of
presidente de Minas Gerais, doutora Bárbara Pá,
Mastology, Dr. Barbara
toda
Passi,
a
and
comissão
others,
organizadora e todos
the
que
organizing
colaboraram
committee, and all that took
para a
part
gente fazer esse primeiro dia
in a many-handed effort
dedicado
to
ao
have this
tratamento do
meeting
tratamento mínimo.
focused on
Amanhã, a
the
partir
therapy
das
of breast.
8 horas
And
tem
tomorrow
mais.
we have more,
Vamos para a
starting
polêmica
at
da
8.
manhã.
We have polemic
Temos os
debates
tumor
tomorrow.
board
We have the tumor
com
board
axilas
with
positivas, não
positive
positivas,
axilla,
pós-papel,
negative
resposta
axilla,
completa e
full
casos
response, partial
esperados
responses, and operated
esperados.
cases,
Até
non-operated
amanhã.
cases. See you tomorrow then.